right?
Right.
Med school at SIU, and then residency at St. Francis here at the U of I, and specialized and certified in emergency medicine, which is always an exciting field. So without further ado, turn it over to you.
Thank you. Appreciate it. I appreciate the opportunity to talk to you guys as well. It's a great honor. I initially was asked to come and speak on AED use, and really what I was telling Dr. Campbell is that AEDs are kind of idiot-proof, and if I was just to talk on AEDs, I'd be here for 5 minutes because everyone can learn to use them. I've had my children play with them, and my 5-year-old, well, he's now 6, but when I first looked at it, he's like, okay, it's pretty simple. So, of course, he was very adept at getting the thing to use. So a little bit about myself. I am from Illinois. I'm from down around the Springfield area originally. I've been faculty at SIU as well as faculty up here at the University of Illinois with emergency medicine residency. I'm currently the EMS medical director. This is my second stint as being EMS medical director for this area. And I've been the EMS director for 5 different Illinois EMS systems, including Springfield, Alton, Ottawa, and then, of course, here twice. And then, in addition, I'm the EMS medical director for all of OSF healthcare system. So I have a pretty broad swath of sort of oversight and collaboration that I do. And my whole focus is to try to improve EMS, improve cardiac arrest survivability. That's one of my big, champion things that I try to do. And we've made quite a bit of headway. I'm a graduate from the Seattle Resuscitation Academy. I did that back in 2013. And since then, I've taken a lot of what I was taught there, brought it here to try to improve our survivability from cardiac arrest. And as physicians, as healthcare providers, we commonly have always had this fatalistic view of cardiac arrest. When we see somebody in cardiac arrest, we think they're going to die. Almost invariably, they're going to die. What we found is that the quicker we get to them, the better CPR we do, the more basic procedures that we do early on, the better chance of survival that we're going to get. So really what we focus on are those people who are in what we call the Utstein criteria. So those are VFib, VTAC arrests that are witnessed. If we can get to them, we can save 60-some-odd% of those. So those are people that are walking out of the hospital neurologically intact. These are not people that are going to a vent farm somewhere or going to a long-term care facility. These are people that are going back to their lives, going back to their families, going back to their jobs. And that's our whole focus here, is to improve their survivability for that. When we first started this initiative, we were well above the national average. National average for VFib, VTAC arrest was between 15 and 20%. We were about 25% when we started this upgrade initiative. Since then, I'm pleased to announce that I looked over the past 13 months, we are now 58.8% survivability for VFib, VTAC arrest. This is no fancy equipment. This isn't a lot of investment in time or anything else other than training and doing things better, using the resources that we have and doing it better. It used to be thought that the more advanced stuff we could do, the more advanced equipment that we had, the better we would be. What we are finding is that CPR is really all you need. You need early BLS, you need early continual CPR, you need to do it properly, and then that not only primes the patient for defibrillation, but improves your survivability and suspends the dying process. And I'm going to show you how that works.
BLS, what's that?
Basic life support.
How do you document that it was a VFib attack?
That is the first impression. That's the first impression arrest by rescuers. So when you get there and you attach the device.
Okay, so he's looking at a
yes.
graph.
Right.
Is that 58% out of the hospital?
Yes.
Out of the hospital.
Yes. Out of St. Francis alone, it was 58.8%.
Okay.
Yeah. So in East Peoria, and if you break it down in our EMS system, and just because even though we have a very large EMS system, it's sort of broken down into geographic areas. For example, and some areas have lower survivability than others. Some of it's related to transport times to the hospital. Some of it's related to, transport times from, EMS providers getting to the patient's side. So there's a lot of variabilities that go into that. But if you look in Peoria, we're pushing it right around the 50% mark. If you look over in East Peoria, it's about 51%. If you look at Fulton County, it's probably down in the 40 area. Collectively at St. Francis, like I said, we're 58.8% survival, and that's walking out of the hospital, going back to their families. So we're well above the national average. If you put that in perspective, Seattle is the world leader at 61. So we're pushing the needle on Seattle. And so I'm trying to get the word out. We're trying to start our own resuscitation academy here in Peoria, which we've done a couple, and it's an offshoot of Seattle's, and we've actually collaborated very closely with them. Recently we had Take Heart America show up, Dr. Lurie. I don't know if you guys know who Dr. Lurie is. He's invented a lot of good things, including various different CPR devices, what we call the rescue pod, which is a impedance threshold device that goes on an advanced airway. So he was here recently at the request of the mayor, harping on all these same things. So without further ado, I'll kind of go with what I have. So I have no financial interest or affiliations. I don't get paid by anybody other than OSF Healthcare. So why do we focus on cardiac arrest? So cardiac arrest accounts for about what percentage of EMS calls? Any guess? It's about 0.5%. So it's pretty small. When you look at the overall number of cardiac or of EMS calls out there, really only about 0.5% are cardiac arrests. So why do we focus on this? So cardiac arrest survivability is very measurable. This is a QA measure that we can look at and we can measure and we can improve upon. And we're finding that various little tweaks within the system have huge outcomes. So if you can't measure upon it, you can't improve it. And then of course, what I always tell all my folks is that quality improvement saves lives. We have to stay on top of our data. So in the whole thing about this lecture is it's about time. Okay, so it's about time. It's about time we did this, and the whole thing is about the time measures that filter into this. So the quicker we can get these measures started, the better survivability they'll be. So when I say TCPR, what I mean there is telecommunicator CPR. And you're like, what is telecommunicator CPR? These are the people, these are the 911 centers, which I'm the medical director over as well. These are when they answer the phone and say, 911, what's your emergency? Their whole job is to identify a cardiac arrest and do it over the phone. And they do it very simply, and I'll go into that in a little bit. But whenever they identify a cardiac arrest and they instruct the caller to start CPR, they're immediately suspending the dying process. Okay, it slows it. So the sooner it begins, the better, and then improves the bystander CPR rates. So we're encouraging people to get on the chest and get it on there quicker and really get the resuscitative measures begun. So high performance, that's what HP CPR, so high performance CPR virtually suspends the dying process. This allows additional time for additional shocks. It allows time for ALS to succeed. So ALS being advanced life support measures. That's your epinephrine, that's your IV therapy, that's your airway, those kind of things, which is another layer in this. But as you'll see, BLS, or the basic measures, are first, and they're really the most important things. The ALS is the icing on the cake, so to speak. All right, survival decreases for about 10% for every minute that treatment is delayed. Okay, so from the time that patient hits the floor and collapses in VFib arrest, 10% per minute. So you look at 10% or 10 minutes out there, their survivability at that point is almost zero. So early recognition and early intervention is the key. We'll go over the 5 links in the chain of survival in a little bit. So again, CPR prolongs the dying process. So 2 important things, defibrillation and time to CPR. So you look at the left there, time to CPR, 0 to 4 minutes, 5 to 8, 9+ minutes, and then you look at time to first shock. And they're both equally important. The further out you get in starting CPR and also defibrillation, you can see down here in the right-hand corner, 0% survivability. So the earlier you get to those things, up there in the upper left-hand corner, the better chances of survival you get. And you can see 64%. Seattle, 61%. So they're really kind of pushing the ceiling on this. And we say 61, 64% because that's the maximum anyone's ever achieved. We don't know what beyond that, if there's anything. So hopefully we can get 75, 80% someday. I don't know. But right now, this is a lot better than what we used to be even 10, 15 years ago. So we'll talk about the slope of death. It's a very precipitous drop. And then I'm going to hopefully get a video here and show you kind of the way things used to be here. So this is a little video that my kids helped me do.
Oh yes, I believe the Confederates left it here. I think they're up.
So CPR, first documented or suspected documented first case of CPR. Does anybody know? Abraham Lincoln.
Oh, really?
Okay, hence the Civil War attire here. So Abraham Lincoln, when he was shot, the surgeons that he had on his staff attempted what they considered to be a cardiopulmonary resuscitation. They did chest compressions, but it involved straddling him and pushing more on his abdomen. And then also their ventilations were moving the arms back and forth, thinking that they were going to make the chest wall expand by doing that. I mean, good thought, but I mean, you can tell that the initial thought process was there.
We should attack it. Gone. Oh. Oh no.
Does anyone know CPR?
Again, my 5-year-old, he knows CPR. He does CPR on everybody. If you're not careful, if you're laying down, he'll do CPR.
Well, this clearly isn't working.
I like those outfits.
Videography was done by my wife. Okay, so now you know it's sort of the way it used to be. All right.
That must have been the video.
All right, so how do we change the slope? How do we change that slope of death, so to speak, that 10% per minute? So first off, we have to improve our bystander CPR rates. We have those people that are the callers. You have to encourage them to get on the chest, to do the right thing, to get CPR initiated. So we have to make it simple, okay? There's several different things. First off, we don't do rescue breathing anymore. We found out that that is the biggest thing that bystanders are afraid of. And it also is not necessary. You have enough oxygen reserves in your body to last for a few minutes. So just hands on the chest. Get on there, pump fast, pump hard, and then wait for the rescuers to get there. Okay, so no more rescue breathing. No more, 5 and 2, 15 and 1, whatever those things that you probably were taught in your CPR classes. And also telecommunicator CPR. We're training our telecommunicators to identify cardiac arrest with just a simple algorithmic approach before they go into any of their dispatch cards. So when they get on scene, they literally do what we call the no-no-go. All right? Whenever they get that call, they ask, is the patient alert? Not awake. Are they alert? In other words, are they talking to you? No, they're not alert. Because people are in VFib, VTAC arrest. They may moan, they may lay there, but they're not perfusing, right? So we don't want to know if they're awake or if they're perceived to be awake. We want to know if they're alert. If they're not alert, the next question is, are they breathing normally? Are they breathing normally? Not if they're breathing. Are they breathing normally? Okay, because VFib, VTAC arrest, they'll have agonal respirations. And those are the people we want to intervene upon. We don't want to wait till they stop breathing. Okay? And if the answer to that question is no, they're not breathing normally, then we start CPR. We're missing a pulse check in there, right? We used to ask for pulse checks. We don't do that anymore. How reliable are pulse checks for a bystander?
50%.
Less than that. It's less than 10%. So when you really ask people, do they have a pulse? Well, I think they do. That's almost invariably the answer that we get. They think, what are they feeling? Their adrenaline's going, right? What are they feeling when they're feeling that pulse? They're feeling their own pulse, right? Because their heart's beating, their blood pressure's high, right? So they're feeling that pulse. They're not feeling the patient's pulse. And so they're not getting CPR because they think the patient has a pulse. All right, so we're cutting out the pulse checks. Are we doing some abnormal, or are we doing some CPR on some people that don't need it? Yeah, we are, but more to no ill effect, okay, other than a sore chest. And most of the people who don't need CPR will tell you. They'll come back. I was listening to a 911 call, okay? I was listening to this, and
I was just sleeping.
This lady called 911, and she goes, and the 911 operator goes, 911, what's your emergency? She goes, yeah, I don't know what's wrong with my husband. I don't know if he's having a stroke or a heart attack or what's going on. And he goes, okay, is he alert? And she goes, no, he's not. He's just moaning. Is he breathing normally? Well, I don't know. Hey, George, are you breathing normally? He goes, no, I don't think he is. He's not answering me. Okay, I think, ma'am, we need to do CPR. She goes, oh, are you sure? He goes, yes, we need to do CPR. He goes, well, he's sitting in a chair. We'll pull him out of the chair, and we're going to start CPR. So she goes, okay, George, I'm sorry, I'm going to grab your legs and pull you onto the floor. So you hear him thump on the floor, and you hear him, okay, I'm going to do a little CPR on you now. As you can hear her talking to her husband as she starts CPR. So she begins CPR, and he starts going, no, stop, no. She goes, it's okay, George, they're telling me you need this. Yeah. He'd had a syncopal episode, but he wasn't in cardiac arrest. But he ended up being fine. But so be it. We had a foul ball there, but he didn't have any adverse event from it. So telecommunicator CPR, get them on the horn, get them to get people to do CPR early. And then the big thing too is public education and training. Okay, so getting it out to the schools, doing social media, telecommunications, getting the local community buy-in. It's a culture change out in our community. We want people to really buy into this initiative, to think that if somebody that collapses, you can make a huge difference in their life. So, and then of course, adopt a high-performance CPR model amongst our rescuers, and I'll go over a little bit what that is. And then adopt the notion that cardiac arrest is treatable and curable. Okay, it's not a fatalistic thing. All right. Early bystander CPR can double the chance of survival. Okay, so getting somebody on the chest immediately can double the chance of survival. In most communities, less than 33% receive bystander CPR. Ours was less than that. when we first started looking at it all across the board. We're now probably more than 33%, but we're still low. Barriers to bystander CPR, again, challenges of arrest recognition. We talked about the pulse checks. Bystander uncertainty to act. Well, I don't know how to do CPR, okay? They think, well, I've never been certified. Well, you don't need to be certified to do CPR, okay? Just do compressions, it's easy. Bystander technical competence or confidence to perform CPR. And this is King County. So King County experience. So bystander initiated, no telecommunicator CPR. When you add telecommunicator CPR, so telecommunicator prompts to that, it over doubles it. So telecommunicators can have a really big impact. So there's your slope of death. There's telecommunicator CPR. So you can see that slope is starting to flatten out a little bit. And then you add in high performance CPR, which means doing the right depth, right rate, and not stopping. It flattens it out even more.
Yeah, in the TCPR, do they tell them how to do it, or
They will. Yes.
or just
They'll
you should
count
go ahead
with
and
them.
start it? Or?
They'll count with and they'll say, we'll do it together. And
Okay.
that's what they're supposed to do.
Okay.
They'll get on the phone and they'll say, okay, put your phone on speaker and listen to me. Okay,
Oh.
we're going to count together. You're going to push fast and you're going to push hard. And let's start. 1, 2, 3, 4, 5, 6. Count with me. And then they'll say rescuers are on the way. So what the dispatchers usually do when they identify a cardiac arrest is they prompt them to do CPR, they instruct them how to do CPR, and at the same time they're simultaneously dispatching rescue units to the scene. So that way they're doing CPR, they're actively engaged in patient care over the phone, and they're getting the rescuers to the patient's bedside. Yeah.
How many operators do you have? I mean, I can imagine more than one of these calls coming in while somebody's trying to coach somebody.
It depends on the PSAP that you're talking about. What I mean by PSAP is Public Service Answering Point, so the dispatch center. And the dispatchers, they do a whole host of things. They do police, they do fire, they do EMS, so they do all of it. And generally speaking, like for Peoria County, we have 3 to 5 on average. They'll be sitting there that'll be answering calls. And so if need be, there is backup, AMT
Or
actually.
they could pass it off to
They
somebody.
can pass it off, yes. And so, they'll sort of answer them in the fashion that they get them. East Peoria, Tazewell County, they're kind of the same thing. But currently, our system oversees Bartonville Police Department. We oversee Peoria County and Peoria City, East Peoria, Tazewell County, Woodford County, and then Fulton County. Those are all of our PSAPs, or our public safety answering points, or 911 centers that we oversee. All right, so we're going to take that slope of death. We're going to put that, remember that 10% per minute. So we start up here at 100% at time 0 all the way down to 10. All right, and we're going to see what, so dispatch. So call recognition, 2 minutes, and this is sort of where you're at, before you do these sort of upgrades. Dispatch, 2 minutes, and that's based on data like back where we used to be. So the whole goal now is to identify that cardiac arrest in that first minute. So, and that's where that no-go falls into place. But 2 minutes may be a little generous even for this. In reality, it may be 3 to 4 minutes. We did a couple of mock arrest scenarios, which I'll kind of go over a little bit, where we had a fake caller. It was one of our ER physicians called, and we had a simulation high-fidelity mannequin down in the location, and then we dispatched our units. They knew it was going to be a drill, but they didn't know what they were getting into. And so it was a drill to gauge the effectiveness of our EMS system, our dispatch centers, and everything else, and see how they would recognize the arrest. They did terrible. They really did. And from the get-go, from the call to the time that they recognized that it was cardiac arrest in one situation was almost 4 minutes. So dispatch was about 2.5 to 3 minutes in there. So turnout means the call is received by the EMS crew. Now they're getting in their vehicles and they're pulling out of the garage, okay? All right. At scene, so this is your scene time, your travel time, from the time they have to leave their crew quarters to when they actually get there. High performance CPR started at the 8.5 minute mark when the patient actually has CPR begin. So there's no bystander CPR in this model. And then defibrillation. So you can see 10%. All right, so that's 10% survival. That's kind of where we used to be. All right, based on no bystander CPR. So let's look at it a little bit different here. So dispatch, again, 2 minutes. Turnout, 1 minute. Telecommunicator CPR. Okay, so now we're getting bystander CPR. The EMS crews get on scene at the 7 minute mark. High performance CPR started a little earlier at the patient side, and they're automatically at 35%. And that's just adding the telecommunicator CPR portion to this. These are a little idealistic numbers, but they are based in a little bit of fact, too. Okay. So So rapid dispatch, so the no-go. You identify it early, you get the units dispatched. They're turned out a minute earlier. Telecommunicator CPR happens same spot. They're at scene earlier because they leave their shed earlier. High-performance CPR started earlier, and now you're at 40%. So you can see how simple measures and simple training, simple culture change can actually impact this greatly. All right, another video. If I can get my mouse to work. There it is. It just turned off. Get my kids.
He's not responding. He's not breathing normally. Does anyone know CPR?
Notice the no-go. There it is.
Don't need to ask him out.
So compressions only. That's what he said.
They just have to explain.
He says, call 911.
Victim is smiling.
I feel better now.
All right. So we'll talk about a little bit. Everybody probably has seen this at some point or other if you've taken a CPR or an ACLS class.
I have-
It's 5 links to change survival.
I have a question, it's terminology. TCPR. The T makes the difference, and the T is that you're talking on the phone to the dispatcher.
That's the telecommunicator.
Okay.
Yep.
Okay,
Yes.
so it's not sending an EKG or something
Correct.
over the phone?
Correct.
Oh, okay.
Yep. We're talking about just getting CPR started early.
Okay.
All right, so we're talking about early access, and again, this is being able to call 911, getting access to rescue services, getting somebody at the chest and doing compression. So time to first compression, time to recognition. And again, early this impacts everything. So you can get things started earlier, you get early defibrillation, you can get early CPR started, the better chance you have for a survival, okay? And also impacts early ALS and ACLS, the things we thought was the real key, which really isn't the key, it's just the icing on the cake. But really, it gets that started early as well. All right, we talked about this. Time call received, time of recognition, so the first no, okay? First compression, second no, time of dispatch, then go. So EMS, rapid dispatch, upgrades in our thinking. And then also another big component of this is getting AEDs in the hands of the police. We all have AEDs in all the police cars in Peoria now in Peoria County. So that was another big initiative that we were trying to look at. So our police officers are getting more adept at this, and they're realizing that we don't necessarily have to do mouth-to-mouth. They do compression-only CPR, and they get the AED. And I've had several situations where I've commended our police officers for early saves. We had one over in East Peoria. It was an off-duty officer, and he was in his car, and he saw a guy swerving in front of him. And so he's thinking, I'm off-duty, right? I don't want to pull this guy over. He's probably drunk. Well, the guy pulled over and kind of crashed his car. He pulled over behind him, flipped on his lights. He got out and realized that the guy was not breathing. Well, he was breathing, but he was unresponsive. So he pulled him out of the car, started CPR immediately. Another police officer, he called for backup. Another police officer came there, grabbed the AED out of his car, walked up, put the pads on there. They shocked him. By the time East Peoria Fire Department got on scene, the guy was breathing, moaning, responsive to pain. The fire department intubated him, began ALS measures, transported him to St. Francis. They identified a STEMI, or an ST elevation MI, en route to the hospital. They called that. The guy went straight to the cath lab, was intervened upon, walked out of the hospital 3 days later, neurologically intact. That was a police save. And obviously they got him to the cath lab. It was all those 5 links of the chain of survival happened in the right manner in that day. So I actually called the guy and I said, hey, introduced myself. I said, how are you doing? And he goes, oh, I'm glad you called. He goes, I'm doing great. He says, good thing his chest is still a little sore. He goes, I think I have a broken rib. I'm like, well, that just means they did a good job on you. And he said, but I don't remember everything. He said, that's probably a good thing. I said, it is. Yes, but he was getting ready. He said, I'm going to go back to my job here in the next couple of weeks. He goes, and he was, I think, 50-some years old, so he's fairly young. So a good success story. All right, we talked about this. Again, is the patient alert? It's the awake responsive. Are they alert? No. Is the victim breathing normally? Then start CPR. Okay, no pulse check. All right, so early recognition, rapid dispatch, early CPR, okay, and this is community CPR training, telecommunicator CPR, and then really training on a high performance model. Early defibrillation, that's what where the AED comes into place, okay? These are everywhere now. And in fact, do we know where our real AED is, the closest real AED? Does everyone know? Right outside the door, right? Right on the wall, okay? So it's always a good thing when you walk into a public venue or anything like that to sort of know where your AED is at, because you never know when you're going to use it. All right, early ACLS, this is your responders, your paramedic units that get on scene. And then post-resuscitative care, so this is the hospital. This is your cath lab, your cooling measures, and then also discharge and care mapping after the patient is a survivor. All right, this is a little bit of an outdated slide. So high performance CPR, HC CPR, we started right around the 23% mark originally, sort of depending on what area of the system that you looked at. Again, when I did this, we were probably approaching 40. We're now in the high 50s now. We're almost where King County was in 2013. You know, so we've really ramped it up, and just over a two-year period of time since we've been doing this, we've shown some remarkable success. And we're now implementing a survivors network. We're getting survivors plugged into Illinois Heart Rescue and getting these people to sort of talk about, you know, life after the cardiac arrest. What does it mean? What does it mean for the family? How do we move beyond that? How do we make public awareness? Because their survivors are key in this. So the people who do survive, they are key in helping other people navigate this and really getting the culture changed. All right, so qualitative factors, we really kind of like put a frame around it. So leadership, training, QI, culture of excellence. And this is sort of what I've been pushing out to our EMS units. So medical model, high expectations. So I set the bar high and say we need to reach this, okay, as the EMS director. And then, of course, we drill. We get everybody. When we first started doing this, I told AMT, I told the fire department, I said, buy a high-fidelity mannequin and practice. I want all of your crews practicing this, and I want you guys practicing together as much as feasibly possible so that you know your role, you know how to do this, you know how to work as a team. Because if you're having hiccups and you're off the chest a lot, you're not doing the patient any favor. And of course, QI. AMT, for example, here in Peoria, they review every single cardiac arrest with their crews. They sit down and review them all. I get advance notification of every cardiac arrest that comes out in our system. I get a text message, so I know that they're going out. If I need to review it, all I have to do is make a phone call, and I can have that chart pulled, and then I can review it. And I can review it with the crew or the agency or whoever's involved, either to give positive feedback or to give a little bit of criticism and tell them they need to do better. And it's all about the culture of excellence, and really it's a big framework around those 5 links of survival. So here's our goals, okay? I want to see 50+% bystander CPR, okay? You say, well, that number's still a little low. I mean, ideally it'd be 100%. Everybody call 911. But you gotta be realistic. You know, not everyone wants to touch a body that's down, okay? Not everybody, and no matter how hard you push, not everyone's gonna do CPR. So if we're at 30-some-odd% now, I'd like to see 50+. Once we hit 50, okay, let's ratchet it up to 75. So let's keep cranking it up as best we can. 90% plus telecommunicator CPR. So that's a good recognition rate. So the no-go thing, we're going to miss a few. We're going to hopefully catch more than we miss. But we want to see at least 90% telecommunicator CPR instructions. 100% high-performance CPR. So this is not a negotiable. Okay, I expect our crews to do the right type of CPR, to do it every single time. All right. If they do, if I go back and say, why didn't this happen? I want to be able to give them feedback and explain to them what's really important here. AED applied in less than 6 minutes and 75%. So if there's an AED nearby, like outside the door, somebody has a cardiac arrest, I want to see that thing on there in less than 6 minutes, okay? Again, it's all about rationing up the survival, get early defibrillation. And then 60+% survival from VFib, VTAC in all communities in our system. And we cover about 9 counties, so that's a big number. All right, so what's high performance CPR? So no matter which model is used or how many responders are present, so you've heard pit crew CPR, where everyone has a little role and they rotate. That can be exceedingly complex and complicated. As simple as it sounds, it can be complex. What I really want them to do is memorize and know the tenets of it rather than the framework of who does what. Okay, so if everyone is on the same board as far as what are the priorities, it will fall into place. CAB, we also say ABCs. right? Airway, breathing, circulation. Airway is really a tertiary concern now, all right? So circulation, airway, and breathing, all right? So the airway, gives way to breathing, so that's why it's CAB. So circulation, it's getting somebody on the chest and getting the compressions done. You want to minimize interruptions in compression. Interruptions count, okay? When you interrupt somebody, their perfusion pressure goes down, you're not doing the right thing. You're not perfusing their organs, you're not perfusing the heart. And it takes a couple cycles to get back up to that perfusion pressure where you really need to be. So you don't want to stop CPR. Very minimal interruptions as much as possible. You want to compress at least 100 per minute. You heard that last video, the staying alive? You know where that came from?
Saturday Night Fever.
Right? But you know where the concept of using that song to be the cadence for cardiac arrest?
Here in Peoria.
It was here in Peoria. Yeah. We invented that. It's all over the place. Have you guys ever watched The Office? Right? And they did this whole parody on, staying alive, and they're doing CPR training there in the office. It's hit national recognition. And in reality, that started here in Peoria. Dr. Hafner, he was very instrumental in getting that up and running. So it's something that we can take pride in. That started here in Peoria. So compress at least 100 per minute. That's your staying alive. Staying alive, right? That's your cadence. Allow complete chest wall recoil and decompression between compressions. So you don't want to lean on the person, okay? If you're leaning, you're getting tired. And what you're doing, if you're not recoiling off of that, you're not allowing the heart to fill full of blood. And when you're doing that, you're knocking your cardiac output down, all right? So the chest is a bellows. You want to let it to recoil. You want to compress, recoil, compress, recoil. You want it to go all the way down, all the way up. You don't want to lean on that patient. The more you lean on them, the worse you're going to be. And you want to do a rhythm assessment every 2 minutes and do that in conjunction with your CPR rotator. Okay, so 2 minutes. And the reason why I say 2 minutes is that's about all people can really stand with manual CPR with doing this model. So if you're going down a couple inches and you're doing 100 per minute, you're going to be pretty fatigued at 2 minutes. Okay, and whether you realize it or not, you're going to start to lean and you're going to start to slow and you're going to start to become more shallow and your compressions will become more ineffective. So if you have multiple people on scene, if you have 2 or 3 people, say, okay, it's about 2 minutes, I'm getting tired, okay, get ready to switch. And as soon as you do that, you're going to switch. If you have an AED, that's when you're going to analyze, okay? So you're going to try to do everything in conjunction so you minimize interruptions, okay? You're going to hover over the patient with the hands ready during defibrillation so the compressions can start immediately after the shock has occurred. It takes, in some defibrillator models, it takes anywhere from 5 to 19 seconds for this thing to charge and wind up. Okay, so the 19 seconds are the older models, and there are not a lot of those out there anymore. But the point being is that if you're analyzing, right, and it says shock advised, and you're waiting for it to wind up and then shock, and then what you're going to do is while it's winding up, you're going to continue to do CPR. And as soon as it says it's ready, then you're going to shock and go right back on it. Okay, no pulse check. Go right back to CPR after you defibrillate. Okay. Okay, the importance of good CPR, like I kind of said before, CPR is the foundation of our resuscitation arsenal. It's the bottom of the pyramid, okay? High performance CPR improves the effectiveness of defibrillatory shock, so your defibrillator is going to be much more effective. We used to say, okay, get the defibrillator, put them on there and shock them early and then do CPR. We're finding that's not the case. Do CPR first and then shock them. What happens when you're doing CPR is you're literally priming the heart for defibrillation, okay? Now, high-performance CPR improves the effectiveness of medication treatments. You're literally circulating medication. So if you have an ALS provider or an ACLS provider and you've got an IV or an IO and you're pushing medications on that individual, CPR is going to circulate them. All right, so how well do we do? This is sort of a busy slide. There's a couple different studies. Essentially, what it's showing is that we don't do as well as we think. And this is why I did a couple of drills in our system. So when you ask a provider, how well did you do? How well did you do in that cardiac arrest? And they're like, oh, I did great. No, you didn't. You did horrible. Okay? They don't go as deep as they need to. They don't go as fast as they need to. Or they start out excessively fast and tire early. And there's more pauses than they give recognition to. When we did our scenarios, our drills, what we found out is in every scenario, the case lasted about 13 minutes. Can you guess how much accumulative time was off the chest in all those scenarios? And it was across agencies. I wasn't picking on one singular agency. I did this across several agencies. So several different communities, several different ambulance providers. Up to 7 minutes off the chest in that 13-minute cardiac arrest. So we're 50% off the chest time. That's not a good outcome. They were pausing to intubate, they were pausing to shock, they were pausing to rotate the patient, they were pausing to put the patient on the backboard to transport them. They were doing no compressions on the cot as they were moving them down the hallway to get them to the ambulance. So that's going to be detrimental. And that's why our survival rates were low. Since then, what we've sort of said is that if they're doing manual CPR, they work that patient at the home. Now, I'm very proud to say that our crews work in a cardiac arrest more efficiently at the scene than what we do in our ER. They really do. And they're experts at it. And so they work them there on the scene if they're doing manual CPR. They do have an automated CPR device now that's all throughout our system called the Lucas device. And it's a very smart device. It's not like your big old air-driven pistons of old. It's an electric device that gives a very consistent and quality CPR. It saves people's backs. It doesn't ever tire. It does it continually. And with that, if that thing is going, once they get that in place, then they can transport that patient and they can get them to the hospital. So we've done a few little tweaks in our system. All right, components of good quality CPR. Better compressions lead to better organ perfusion. I mean, this is pretty common sense, which leads to better resuscitation. The greater depth, increased likelihood of successful shock. Compression, when you're going down, that's your organs, okay? So you're pushing the blood out of the chest, now of the heart. So you're getting to your organs there, okay? So that's your cardiac output. When you recoil, the coronary arteries, they fill in diastole, all right? So when you're recoiling off that, the coronary arteries are filling. You're still providing your heart with a little bit of energy there, okay? So compression, increased intrathoracic pressure, you're literally expelling all the blood out of the chest and out of the heart. So it injects the blood from the lungs and hearts. Good compression increases forward output and blood pressure. I actually had a patient when I worked down in Springfield who came in. She was fairly young. I think she was probably a PE. She was like 48, 49 years old, and she had a cardiac arrest. And she was initially in VFib. We shocked her a bunch, and she was asystole at this point by the time we got her. When we were doing compressions on her, she was awake. When we stopped doing compressions, she'd go unresponsive. She had no pulse, no cardiac activity. She was awake enough to where she would respond to commands, nod her head, and hold my hand. It was the most eerie thing I've ever seen. But we did really high quality compressions, and you talk about a scenario where it was really difficult to call an arrest, but there was no survivability from that, unfortunately. But good compressions will perfuse your organs. Decompression. So decrease intrathoracic pressure. Okay, so you're literally, remember it's a bellows. You're sucking blood back into the heart, and you're actually going to have a little bit of coronary perfusion there as well. So does pausing make a difference? We said yes, it does. The longer pauses in chest compression, the lower chances of positive outcome. The more you pause, the more cumulative it becomes. And this is sort of what I was discussing a little bit before. So when you start with your CPR, kind of here during your systole, so here's your CPR, you're ramping it up. As you do CPR, this is your perfusion pressure, okay? This is your forward cardiac output. This is your cerebral perfusion pressure. When you pause CPR, look what happens. It drops all the way down to zero again, okay? And then it takes a moment for it to get back up there. And it ramps back up every single time you pause. So it's a very important thing not to pause as much as possible. This was actually a swine study. So what they looked at is successfully resuscitated swine that were put into cardiac arrest. So they looked at the seconds of interrupted CPR. So the more seconds of interrupted CPR you did, the less chances of survival. All right. So if decompression is incomplete, compression is not as effective, right? Because you're just not moving as much blood around. 75% of decompression rather than 100% decompression does not provide sufficient coronary or cerebral perfusion. So you're not going to get your ROSC or return to spontaneous circulation. So inadequate decompression, in other words, leaning on that patient, is going to compromise both your forward outflow, your cardiac output, as well as your coronary perfusion. So very limited, even limited interruptions add up over a period of time. Even a few seconds add up, so you want to minimize them as much as possible. And the effect of medication, so perfusion, we said before, doing good quality compressions is what's going to move that medication around. It's going to move all your epi and everything else around. Move past that. So ventilations. We used to say, how many times have you seen a cardiac arrest in the past, and they're just hyperventilating the patient, right? Ventilate them. They need oxygen, right? So you just ventilate. When you go into an artificial form of ventilation, we're going from, normally when we breathe, we have negative intrathoracic pressure. We're pulling air into the lungs. When you're doing positive pressure ventilation, you're having a bag or you're doing mouth-to-mouth, however you're going to do it, you're pushing air into the lungs. When you're doing that, you're creating a positive intrathoracic pressure. You're going to impede blood return. So you're going to impede blood return back to the heart. You're going to make your CPR very detrimental. So hyperventilating can be a bad thing. So we always tell people that, if you're going to ventilate, do it very sparingly. In fact, our rescuers use a pediatric bag valve mask for adult cardiac arrest for that reason. Lower tidal volume, lower positive pressure, better outcomes. We've measured that. Instead of doing the 15-2, so pausing to do 2 breaths, we do 10-1. So 10 compressions. So if we're doing manual CPR, 1, 2, 3, 4, we count to 10, and then breath. Okay, so the airway provider is listening to that counting, and they're providing a little synchronous breath every 10 compressions. So the AHA lags behind us. That's what we always say.
I'm kind of in a quandary because I thought with increased pressure, oxygen penetration to the cells would be higher. But you're saying, and of course if you go too fast, you're just moving dead air. You're not getting air into the alveoli, right?
Right.
But you say if you do it too much, you're actually impeding blood flow into the heart. You mean ventricular filling?
Correct. Because you're moving from a normal physiologic negative intrathoracic pressure when you take a breath to making it a positive pressure ventilation. So whenever you do that positive pressure, remember the chest is a bellows.
Yeah.
So when you move in positive pressure air into there, you're impeding
So you
the
use
passive
a
blood.
pediatric bag so you push less air in? Is that
Correct. So less tidal volume, less pressure.
how fast are you doing that?
We do every 10 compressions.
Every 10, okay.
Yeah, every 10 compressions you do a small breath. It's just enough to keep a little bit of oxygenated
So
blood
if
moving.
you're saying if you've got it available, that's ideal, but you don't, it's better just to keep pumping and not worry about it.
Right. And initially for bystander CPR, if you ever run across a cardiac arrest out in the community, just don't worry about ventilations. Just do hands-only CPR. That's the most important thing. Okay, so how do we reliably improve and achieve our high performance model? So we do real world scenario based training simulation. Like I said, when we did our training simulation, we involved actual 911 services and we involved duty crews, so crews that were on duty at the time. They walked in that day not knowing that they were going to be put on a surprise drill. We put them on notice, and they know that they can expect these kind of things. And even after we did our drills, our own agencies will pull their duty crews in and go, run an arrest. Let me see you do it. And so they will do these kind of trainings on their own. So kind of getting that ball moving so that they can continue their own training and really change the culture. We want to have enough manpower on scene as well. We want to have enough people there at the patient's side in order to do effective resuscitation. What we found is that the ideal number is about 5. So 5 people. We usually have one person standing back, and they don't do anything. They're hands off. They usually are a timekeeper. So they're a task orienter. They don't have to be a paramedic. They can be an EMT basic. They can be a captain on the fire engine. I don't care who it is. But if they're sitting there, they're literally sitting there with a stopwatch and a clipboard. And they're looking at people and going, it's been 2 minutes. You need to switch. It's been 5 minutes since your last epinephrine. They're keeping everyone on task. They're keeping everyone oriented to what they need to do. So, and really the other providers, that way you don't get too cluttered of a scene. I've been on cardiac arrest where we've had 7, 8, 10 people. They're just in the way. The last arrest I do, and I do respond to calls out in the community. I went on a cardiac arrest. It was actually at the Proctor Professional Building. When I went there, it was myself, my paramedic partner, it was the fire department. Then another fire engine showed up. They self-dispatched themselves. Then AMT showed up. By that time, we had 3 defibrillators on scene. We had all these extra personnel. One of the firemen tripped over my intraosseous line and pulled it out. Fortunately, I was able to get another one. We did get a return of spontaneous circulation on that patient, and we transported the patient to the ER. But too many people clutter the scene. And not only that, when we got outside, there's 2 fire engines, our response vehicle, and AMT, and we're trying to find the ambulance. And it was behind the fire truck, which was parked. There's 2 of them there. So there's too many people. So 5 is a good number. 5 to 6, probably no more than that.
What are the other 4?
What's that?
Tell us what the other 4 are tasked with.
Usually they're tasked with doing BLS measures, so we'll have one person at the airway, one person doing CPR, and those people will rotate. There's usually another person helping getting equipment out and ready, and another person sort of on standby to come in and do measures if the other person gets tired or fatigued. So, and then they rotate positions. And like I said, and then usually a taskmaster, somebody sitting there that's able to actually keep people oriented and keep people moving. So train, drill, this is what we do, okay? So we got to keep our training very simple. We got to keep it realistic. We got to use scenarios, base our scenarios off of actual real life cases so that they learn from them, and then completely hands-on. So impromptu drills is what we did. We do these, we do shift skills. Our supervisors for our ambulance departments, they go in there and they have them innovate a mannequin, or they'll have them do CPR. They'll run them through a code scenario. So these kind of things just keep their knowledge base moving forward. So it's much easier for a provider to remember these things and to change their culture than to be continually lectured. The more they're lectured, I mean, it just becomes a lecture. But until they're actually out there doing it and getting the muscle memory of doing it, then they won't really remember it. So we can write all the protocols we want, but if you're not actually doing it and practicing it, you're not making any benefit. So, like I've said before, if you can't measure it, you can't improve it. Measurement improvement is really sort of the whole foundation here. So going back sort of in summary, this is like a good summary slide, the pyramid of resuscitation. So early recognition and early CPR, high performance CPR, followed thereafter by early defibrillation, that's your AED, and then early ACLS, those are your ambulance providers, your paramedics that get on scene, and then also expert post-resuscitation care. So this is putting people on extracorporeal membrane oxygenation, this is cooling measures, this is cath lab measures, this is good quality ICU care. So these are, and then post-discharge care mapping. So that's the expert post-resuscitation. That's what we do in the hospital. So my realm is all the bottom part of the pyramid. So, yeah.
Questions. In terms of differential diagnosis, I remember one of the cases that I had in the ER in Houston was a cafe coronary.
Mm-hmm.
It was assumed it was myocardial infarct, brought into the cardiac room, and I was the tube guy, and I found this big chunk of steak, lodged.
Sure.
Any thoughts in terms of the differential diagnosis for that or others?
That always plays into it. Obviously, when we're talking about VFib, VTAC, or rest, we're talking primarily either some sort of cardiomyopathy, or we're talking probably, then treatment is the same. So if you're looking at that kind of a potentially lethal arrhythmia, the treatment is the same. So, but when you're looking at PEA, for example, obviously your 5-H's, your T's, your acidosis, your temperature, and all these various different toxidromes, things like that do play into that. Your algorithmic approach doesn't change much on the initial resuscitation part of that. If you're concerned about an airway obstruction, and I've been there as a responder, I have an EMS background, I didn't really say that. I had 6 years, I worked as a medic 6 years of combat medicine experience, plus working on a helicopter for a number of years. That's sort of how I got into EMS. But when I've been there before, when we think, well, we have cardiac arrest, and I put the laryngoscope in somebody's mouth and it's full of vomitus, and then I pull a chunk of turkey out of their airway. So obviously those things do occur, and that's part of your more advanced, skill set when a paramedic gets on scene. So all in all, though, the initial resuscitation is the same of all causes. Whether you're in PEA, asystole, VFib, VTAC, you have something lodged in your esophagus, you're going to start compressions first.
Would the compression actually be a form of, what's that guy's name?
Heimlich?
Heimlich?
It can.
Okay.
It certainly can, and I've seen that happen and with good effect. So,
Would you just go through the 5 minutes to show us the AEG,
Yeah,
including taking it off the wall?
yeah, absolutely.
Just step by step.
Absolutely.
I'm not sure I would be able to do it, even though.
Right. If everyone wants to come up, I'll let you guys look at it, play with it, and run through the algorithm. It's fairly simple.
So
Like
do
I
you
said,
have to break the glass? In the old days, we used to have to break the glass.
Most of them you don't. Most of them you can just open it up and grab it off the wall. So, but this model here is a trainer device. It's not a real device, but it functions and runs through the same thing. So this device is very similar out there, and I'll kind of hold it up here. If you look up here in the corner, and this has a little device, I can change it. So if there's a red X on there, that means the battery's bad. That means the device is not going to work. Okay, but if you see like a little hourglass shape, black hourglass shape, that means the battery is still functional. It's on standby. All right, does that make sense? So you'll see that the first thing you're going to do, obviously, you're going to start CPR. While somebody's starting CPR, have somebody go retrieve the AED. When you grab the AED, you're going to turn it on.
Low battery.
There's it says low battery.
Apply pads to patient's bare chest.
Okay, so what you're going to do is you're going to make sure
Plug in pads connector next to flashing light.
So you go, these don't stick real well, but there's a good diagram. You peel them off the plastic, and it's going to show you right on the chest.
Apply pads. plug-in connector.
And it's just literally going to tell you how to do it. You know, apply the pads, and again, they don't stick real well. But once they're on there,
Is that, the one is over the sternum and the other one is at the apex,
Yep.
is that right?
correct. And if you, it'll show.
Analyzing heart rhythm.
So once it's plugged in,
Do not touch the patient.
it'll walk it through with you, and it'll tell you exactly what to do.
Shock advised.
Okay? So
Charging.
you'll hear it charge.
Stay clear of patient.
Now, generally speaking, it'll tell you to stay clear while you're
Deliver
charging.
shock
You don't
now.
have to.
Press the orange button now.
It'll beep at you. It'll flash. And you just hit the button,
Shock delivered.
and it'll give you a shock.
It
Pause.
won't do it automatically.
Begin
You
CPR.
have to punch the.
You don't have to punch anything. There's two main buttons there, and it'll run through everything with you.
And is it
Very
picking up
simple.
the heart rhythm?
Yes.
It's doing an EKG in a
Yes.
sense.
Will they
Yeah.
shock if it's asystole?
No,
It will not.
it will not. It'll only shock if it detects VFib or VTAC.
Oh, it detects it.
Yes.
But you can't do this, if you're by yourself, you just gotta do the compressions, right?
Right. Correct.
You gotta call 911 and do
Yep.
the compressions. Okay.
Yep. You start your compressions, call 911 or have somebody call 911 for you.
Yeah.
If you know that there's an AED in-house, if you're by yourself, I would still say just continue CPR as much as you can.
Right.
If you can quickly grab the AED, grab it. Otherwise, you yell for help and have somebody else grab the AED while you do compressions.
Now, why would it not function with asystole?
Because it's non-shockable rhythm.
So it's
Yeah.
strictly related to rhythm.
Correct. So the machine will actually identify the rhythm for you, and then we'll shock accordingly.
I see.
So tachydysrhythmias is really what it's developed to.
Is that what was wrong
Will
with
it
that
shock
girl
for
you said?
SVT?
Usually not, just because most SVT is narrow complex, and this thing will pick up the wider complex.
Well, they're
rhythms.
usually not
So-
unconscious either.
Correct. Right.
Does that record the rhythm?
They do.
They do.
Yeah, most
They do.
most of these do. I wouldn't say all of them do, but I know a lot of the Philips monitors do. A lot of the other brands do as well. We had one recently out at Paradise. Paradise has their own EMS agency. I don't know if people knew that, but they follow in my direction too. And they're EMT Basics. They have a defibrillator, and they just had a save the other day. They had somebody that was gambling, and they keeled over, and they started CPR immediately. One of the bystanders did, and then the EMTs there were called on scene. They had their defibrillator. They shocked the person. The person was awake and talking by the time they got the ambulance there.
Their EMTs are on site 24/7?
Yep, at Paradise.
So they're paying for that.
Yep.
A
they
lot of
are.
excitement there.
Yeah, right? Yeah, I'd say they're publicly paying for that.
Stop CPR.
So it literally will walk through everything for you on the device. Yeah.
Now, next question that comes with, like, you have to check your fire extinguishers and make sure they're charged.
Mhm.
Who, when there's an AED purchased or installed, is there some reminder given to check the battery?
There
or-
should be. That's a very good question. It depends on who owns the defibrillator. Locally, I know AMT has donated a lot of AEDs out into the community. And in those situations, it's sort of, I'm not sure, I don't think AMT is the one who actually checks the batteries. I think it's supposed to be the individual business or location. They're supposed to at least go in there and make sure that the battery indicator is good. It should be on a routine checklist, but you're very right in some scenarios that is not the case, and that's why it's important to look at it, because it's not going to be functional at all if it has a big red X across it.
What kind of batteries are they? Can we replace them?
It's a proprietary battery, and this one I don't think has that same type of battery, but it's a proprietary battery that fits into the device.
Like lithium?
I think most of them are lithium based. Yeah,
So, they should stay charged quite a while once.
they do.
Yeah.
It isn't, and they should be doing. And like I said, you shouldn't have to power it up to see if the battery's on there. Most AEDs, and the Philips ones especially, have a little window up in the corner that'll tell you the battery's good.
Are people buying them for home use?
They are.
And what are
How much are they now?
That's a good question.
$150.
They were $2,500 when
Yeah.
they first came out. I don't know what they
They're a little less.
They're
than that
about
now.
200, aren't they?
Yeah, you get one in the hundreds now. Depends
They're
on
more
what
than
model
that.
you want.
And where are they now? You said, I know AMT has donated them throughout the community. Are they in every school, for example?
Most schools have one.
Our church has.
Large
Right.
buildings,
A lot of
churches.
School, yeah. A lot of businesses have them too. If you want, if you have a smartphone if you go to the App Store or wherever for your smartphone, the AMT has actually paid money to get the Pulse Point software. What Pulse Point is if you are a registered user of Pulse Point, it will tell you, that, for example, if we're sitting here in this building and I'm a Pulse Point user, my phone will go off if there's a cardiac arrest, if I'm in the vicinity. And I actually responded to one day. So my phone, I'll get an alert and it'll say cardiac arrest, School of Medicine, second floor, or wherever. And then I'm like, oh, I'm right there. So I'll go there, and it has a map that you push the little button on there. It'll tell you where the AED is, and then it'll have algorithms that'll actually tell you how to use the AED and how to do CPR. So the app is very good with that. And that's something that EMT has put money to use.
I presume the Good Samaritan law is applied to resuscitation?
Yes, absolutely.
Yeah.
This is a little bit off subject, but my experience is that, and this is obviously what you've been talking about, is sudden cardiac arrest due to a cardiac arrhythmia.
Right.
I've been concerned that on-site resuscitation occurs regardless of what the cause is,
Right.
sometimes inappropriately,
Right.
after it's 4 hours of submersion, for example.
Mm-hmm.
And people are trying to resuscitate people, or maybe smoke inhalation or whatever. What do you teach the on-site responders about not doing CPR, or do you?
It's obvious if there's several different scenarios there. There's a number of things that we could get into. For example, if we get there and they have a valid DNR, or they have a surrogate decision maker, let's say they were a hospice patient, or they were somebody who was advanced age or whatever, and they had a lot of comorbidities, and the family member says, I don't want you doing anything. At that point, then obviously they call medical control, so they'll call one of our physicians and then go over that, and it takes the onus off the provider and puts it onto the physician to say, yeah, I agree, no resuscitation at this point, go ahead and call the coroner and get the ball moving there. So that would be one scenario that we'd run into. Another one would be, like, for example, prolonged submergence. Obviously someone who is down, who has no signs of life, who they've been missing, and it's obvious they're deceased. So, or if there's a trauma and there's obviously no signs of life, or the injuries are incompatible with life, massive head injuries, massive penetrating trauma, those kind of things. Those scenarios, really a resuscitation is not warranted, and in most scenarios it's something that is not effective, so we would not resuscitate somebody at that measure. If there's obviously a prolonged downtime, there's signs of death, rigor, lividity, fixed dilated pupils, asystole, especially in 3 leads. When we see somebody that's in asystole to begin with, their heart is literally out of ATP. It's out of energy. In most scenarios there, the chances of survival are less than 5%. So in those, it's a dismal survival rate in an asystole presentation. But if there's any signs of death to begin with, or it's prolonged downtime, they're cold to the touch, we don't resuscitate those.
To take that a little further, you've described all these attempts where you may get somebody back, but how do you decide when to stop?
Again, and it depends on rhythm, it depends on the scenario. For example, I'll give you a couple of good examples. We had one, we get the scenario commonly, we'll get an asystole arrest, and oftentimes we do not transport asystoles. So if we get a patient who's asystole, maybe from a nursing home or something of that nature, and you get there, and let's say it was a fairly witnessed arrest, and let's say the nursing home staff started CPR, and let's say they are not a do not resuscitate, but we get there and they're asystole by the time the providers get there. They'll run through 3 rounds of ACLS algorithm, so they'll give 3 rounds of epi, they'll provide an airway, they'll do CPR, they'll shock if need be, and if they have no luck after those first 3 rounds, then we usually call it. Data is showing, we used to say give epi, epi, epi. We used to do high dose epi. We give 5 milligrams of epi, 3 to 5 milligrams of epi in some situations. What we found is that the more epi you give, the worse the survival. We'll get a return of spontaneous circulation, but that person's not walking out of the hospital. It kills the brain. Basically causes such bad vasoconstriction in the brain, it kills the brain. So you may resuscitate the heart, but you're killing the brain. So more than 1 to 2 milligrams of epi we found have been very, very detrimental. That said, epi given earlier, the earlier you can give the epi, the more chance you're going to get at getting a spontaneous circulation. So it's a time-dependent thing, it's a rhythm-dependent thing. If you have a PEA, for example, we transport most PEAs just because it's usually a secondary cause of arrest. It's one of those 5 H's and T's. It's a PE, it's a temperature problem, it's a toxidrome. It's acidosis or wherever you want to say. So, it's a hyperkalemia or something of that nature. There's something there that is a secondary cause of that arrest. So we want to make sure that we're treating those things and we get those patients to the hospital as quick as we can. So VFib, VTAC, we work them until we get a pulse. If they go asystole, we work them until we don't get anything, and then we will generally call it.
Did that thing say cease resuscitation or something?
It did. It's a trainer, so its algorithm is it runs it through,
Oh.
and it tells you to shock, and then eventually it'll tell you to stop CPR, just because it's assuming in the scenario in here that you got pulse back.
Oh, I see.
Yeah, or that you got.
The usual ones won't do that.
Yeah.
Okay.
Right.
This is really great for how you're managing community response to these. If they're in the hospital and arrest, first of all, it's all resident driven then. But are you doing the same thing with resident evaluations that you do with all these other people?
When they're in the ER, they run it the way I want to run it. If it's up on the floor, that's a whole different scenario, because that's usually falling into the ICU and the code team.
But you don't have anything to do with that?
I have very little to do with that.
Should you?
Maybe. I would like to.
Because I'm not sure how well they look at each one of these arrests and monitor it the way you're doing it as though it happened in Kmart.
Right. Exactly. And our in-house arrest model should mirror what we're doing pre-hospital. And it used to be that the hospital drove what we did pre-hospital. And I'm finding now the tables have turned in a large sense. When I introduced the intraosseous devices out into the field from the pre-hospital side of things, we didn't have them in the ER. It wasn't until we used them out in the pre-hospital realm that we then started using them in the hospital. The Lucas device too, the automated CPR device, we started using those in the pre-hospital realm. Now we have them in the ER. So it's like the tables have turned. I think in a large sense our EMS crews are pushing ahead and the hospital's lagging behind, and I would really like to have more say in that. So if you can get that accomplished, that'd be great. Yes.
Question, can you tell me a little bit more about the intraosseous device? I assume that that's in lieu of trying to find an IV in a collapsed vascular system?
Correct. If we can get a proximal upper extremity vein on an IV, that's preferable. Or if we can do an external jugular or something of that nature, it's a direct route right to the heart. However, and also it's a lot cheaper. So if you can do an IV quick, we usually say do a couple of attempts. If you can't get a peripheral IV, then go to an intraosseous device. So what we have is a drill. It's called the Easy IO. The actual drill itself is good for 500 drills, so 500 usages. So they last for a long time. And it is a disposal device. It's several $100s for the actual drill, but they're not going to exhaust it in any time short. So the drill, the actual needles are what's expensive. Each needle is a cutting needle, and it has an introducer in it, and plus it's a hollow needle. So each one of those needles, because of the way it is, and it's designed to drill through bone, is about $100 just for the needle. That's why we try the IV first. So if we can't get an IV, we go through the drill. And it literally slips on the end of the drill. We prefer in a cardiac arrest to do proximal humerus. If you do a proximal humerus and we're putting a 16 gauge IO device in there, it is the same as doing a subclavian central line as far as route of administration. So you're pushing that medication through there, it gets into the central circulation about the same amount of time as if you had a central line.
You don't use the tibia anymore?
We do. The problem is we use it as secondary source. So we have 3 sites: the humerus, tibia, and then medial malleolus. So those are the 3 sites that we typically will use for an intraosseous device. The problem with the lower extremity is it's below the diaphragm. So it's a lot longer time to get back to central circulation. It's not as effective. So
We just used bone marrow needles in the old days.
Right, we had those too. And,
The tibia.
right, and
That's in children though. So
Right.
that's
Well, we use them in adults too. They're not highly effective. And of course, trying to get through the cortex of a bone on an adult with a Jamshidi device is pretty
amazing way to
hard.
resuscitate.
Yeah.
Amazing.
There's several
Put
other.
anything in there. Are there any drugs that you can't use in the interosseous?
Anything you can use intravenously, you
That's
can use
what I thought.
intraosseously. Yeah. And there's several others for the tactical environment. Like when I'm on several different. I'm a police physician, so I cover several different SWAT teams as well. And I use a device called the FAST IO device, and it's a sternal IO device. And so we use that because a lot of times people are shot in the extremities, and so if you're shot in the extremities and you're putting tourniquets on, you're kind of shooting yourself in the leg, no pun intended, to try to put an intraosseous device in there. Yeah. So we'll do sternal. So it basically injects the needle into the sternum, usually the manubrium. And again, the time of the central circulation through a manubrial IO device is the same, essentially, as the central line. So.
Doesn't the sternal device interfere with the compressions? I mean,
no, because we go with manubrium.
Oh, okay.
Yeah. The problem is with the manubrial device is, if you've ever seen it, it's pretty medieval looking. There's what they call a needle set. There's several different gauge needles that sit around the central firing device. So that needle set penetrates through the skin, hits the bone, and then you're pushing on the bone. When you're pushing on the bone, then it fires the actual needle into the manubrium. And then pull it out. But when you're done, you'll see a ring of needle holes with your catheter coming out of the manubrium. So. I don't let our normal pre-hospital providers use those. We use those for a tactical device only.
Thank you very much.